We'll start, sir.
Yeah, please.
Here is a 3-year-old male child who is brought by his parents. He is the firstborn male child by consanguineous marriage, and he was antenatally diagnosed with bilateral hydrouretal nephrosis and oligohydramnios. He is a preterm child delivered by normal basal delivery, and his birth weight is 1.8 kg. This is the birth history given by the parents. On day 3 postnatal, child serum creatinine is 2.8 and electrolytes normal. And ultrasound reported bilateral hydrouretal nephrosis with an distended bladder. The child had underwent posterior urethral fulguration on postnatal day 4.
Just hold on for a moment.
Yes, sir.
Let me ask you, who is Dr. Nayan?
Yes, sir.
Yes, sir.
What is the serum creatinine of a newborn child?
So normal create will be 0.4 to 0.6 milligram per deciliter. So newborn.
Nayan, you should answer like this. It will
Yes, sir.
be fetal creatinine.
Okay, sir.
Fine. So
Yes, sir.
it may be 1, it may be 1.2, it may be 0.8. It will reflect the maternal creatinine.
Yes, sir. So within,
Creatinine
48
will, in 40 to 72 hours, it will
Yes,
come.
sir.
So usually, suppose a month-old child or say 3-month-old child, what will be the creatinine?
The normal create for 3 months would be, sir, 0.4 to 0.6 milligram per deciliter.
Okay, yeah, that's good. That's good. Maybe there is response to 0.4.
Yes.
Okay. Go ahead.
Post fulguration, the child's creat is 3.25, which has increased. For that reason, the child had undergone a vesicostomy on postnatal day 6.
So why the decision was taken? I hope you understand these.
Sir, can I summarize, sir?
Yeah,
from
please,
first-
please.
So, sir, this child presented to us at the age of 3 years, and mother gave us history of this antenatal hydronephrosis. So, I would like to ask mother whether any detailed ultrasound details available in the form of the APDs of the bilateral kidneys, any renal cyst, corticomedullary differentiations, how severe this bilateral hydrourethral nephrosis, also the details of bladder and the posterior urethral dilatation. But that details were not available, sir, on presentation.
Okay. Mm-hmm.
The second thing, they mentioned the preterm 8 months normal vaginal delivery. So I want to know the complete birth history. As the child born as a preterm, any what is the severity of oligohydramnios? Any the respiratory birth weight? Obviously, they are given 1.8. Any other respiratory issues after birth? What the interventions the neonatologist had done? So, what is the urine out when the child passed the urine? Any the stool passage? All this detail is not available. So, I would like to ask all this detail.
Sure, these are all important.
Yes.
At the same time, since if suppose by chance such a case is there, or you are asked this in your Bible table, so you should be able to tell that what is the protocol of doing ultrasound in the normal pregnancy, and if you detect something wrong, then what is the protocol? Fine, I hope you are aware of these.
Yes, sir.
Okay. Can you just repeat for benefit of all your colleagues? You will be working in a hospital where the pediatric cases are quite frequent. In other, I see there are some 20 participants. So all may not be exposed. So just for their benefit, just tell that in a normal pregnancy, what is the screening protocol?
So, sir, we here we follow our urinary tract dilatation protocol, UTD protocols. If the child mother comes antenatally, if mother comes on the second trimester, less than 28 weeks, so the normal APD will be less than 4. If any based on the APD level, if 4 to 7 will categorize as a mild A1, and if more than 7 to 10 will categorize as a intermediate or high risk. So if low risk, we'll just advise to the repeat the scan in the third trimester. And if it's intermediate and high risk, we'll advise the two scans in the third trimester, one after 1 month and then later before the around 8 months.
Yeah.
So that is the antenatal protocol we are following, sir.
Yeah, that's very good. And the detection of oligohydramnios, does it make it something special?
So, if basically we have to look for the severity of oligohydramnios, sir. If it's a severe oligohydramnios, we have to look antenatally, ultrasound only. We have to look for the renal anomalies, any lower urinary tract obstructions in the child, fetus. So based on that, we can counsel the parents regarding the severity of problem, and we can give the options. If a too much severe LUTS problem, lower outlet flow obstruction, then we can advise the abortion also, and also we can give the options of fetal intervention if required.
Okay. So oligohydramnios is a ominous sign because the fetal urine contributes to the amniotic volume. Okay. So
Yes,
what means the developing fetus is not passing sufficient amount of urine. That's one cause. Second,
yes,
presence of oligohydramnios also raises the possibility of pulmonary hypoplasia.
yes, sir.
So these 2 points you must emphasize. So therefore, as you were saying that neonatal history and neonatal period history you are asking this thing only, whether this child developed any kind of
A complication related to oligohydramnios.
Yes. Okay, very good. So on the postnatal day 4, and as you said that day 3 the creatinine was 2.87, obviously it is higher than the maternal creatinine. So it was raised. Okay.
Yes.
And naturally, posterior valve fulguration was done on the day 4. So what kind of instruments were used for that? I am asking because many of your colleagues have not seen. I am sure about it.
For fulguration, sir, instruments
Yes.
for fulguration. So in our institute, sir, we have 9 French resectoscope with the Collins knife and 0-degree telescope we will use. If it's a preterm baby or if it's not allowed 9 French, then we will use the standard infant cystoscope of 4.5 French with Begbie's electrode. The 2 instruments we have.
Okay. So the 4 French cystoscope has got a working channel?
4.5 French having working channel of 3 French.
Okay. And with that, what accessory you use to fulgurate the valve?
We have Begbie electrode, sir, for that.
Okay. Begbie electrode. That's very good.
Yes.
That's very. So that is important. And did the meters need dilatation to pass the 9 French resectoscope? Because your months will vary.
Can you repeat, sir? I'm not able to.
This was a 8 months old preterm baby.
Yes,
It's
sir.
preterm by almost 6 weeks or so.
Yes.
The external meters admitted the resectoscope.
It won't allow, sir, for 9 French, obviously.
Yeah, that's what I'm saying. Yes.
Yes.
Okay. Good.
So this is, sir, on the day 3, they reported K of 2.8 and the fulguration done on the post of day 4. But again, I don't have the details of the fulguration, the interim findings and the other details and post-op diuresis, electrolyte imbalance. We don't have much of detail. So I would obviously ask post-fulguration, the status of the hydration status, any infection episode, electrolyte imbalance, and respiratory issues. So because the important post-fulguration, obviously we have to take care of about the UTIs and dehydration, diuresis. So I would like to ask all those details if available.
This was done elsewhere, so we don't have the details of fulguration status and how many days the catheter was left in situ, or the information regarding diuresis was not there since it was done elsewhere.
Dr. Nayan,
Yes, sir.
question would be, what would be, so this was in center, it was known antenatally and it was detected and it was treated. Not there. What is the common mode of presentation of the newborn babies with posterior urethral valve?
Sir, most of the babies will present with because they will do the ultrasound on the birth because of prenatal hydro. So the babies will come with after birth respiratory distress and ultrasound showing the severe hydronephrosis with classical features of the posterior urethral valve. So
one important mode of presentation is with UTI.
Yes, UTI.
Yes, because of the obstructed system, the distended bladder and the distended kidneys, and their creatinine will be raised, so they are at a very high risk of developing infections, and they often develop septicemia.
Yes, sir.
So that is important. In the neonatal world, one of the common cause of septicemia is this obstructed lower urinary tract. Okay,
yes.
And so suppose you find the child in that situation, what do you do?
Sir, the after birth, if I feel it's a sepsis patient, child in the sepsis, I will start with the IV fluids. I will start with the IV antibiotics. I will send the urine analysis and the cultures. And obviously, after if I will confirm my diagnosis, and then I will put the catheter, the infant feeding tube, and I will observe the diuresis.
Yeah, the number. The first thing would be you put a urethral catheter, a feeding tube. This will always go.
Yes, sir.
Always go. This.
Sir, catheter, the literature says the catheter introduction will be sometime it's difficult because of the high bladder neck. But usually infant feeding, what we are practicing is infant feeding tube, five French. So it will go, sir.
Yeah, 5 French feeding tube will go. 4, 5 or 6 French feeding tube will go, depending on the need.
Yes.
Okay. And the first thing is that such babies should be supported. They are brought back from the septicemia and their kidney function might improve. And then you can investigate to proceed further. Okay?
Yes, sir.
Okay. Now, in this baby, the decision was made to do a vesicostomy on the postnatal day 6.
Yes, sir.
Why was it done? Or what is your interpretation on this?
They may thought because of the raised create, they have done the vesicostomy, but I am not agree with this management, sir, because I think the fulguration is done on posterior 4. And this is, I think, too early to do the vesicostomy. We could have wait for another 2 days, because sometime after fulguration, the create may jump because of dehydration or UTI. So if we could have waited for another 2 days, we have better idea whether we need vesicostomy or not.
Yes, fully agree.
Yes.
Because what you have achieved by doing a vesicostomy can easily be achieved by putting a feeding tube, nothing else.
Yes, sir.
Yes. So suspicion is what? Suspicion is rectal obstructions.
Yes, sir.
Okay. So anything more in the history?
Yes, sir. Sir, post vesicostomy, 3 months, the creat of the child is 0.8, and electrolytes of potassium marginally raised of 5.6, and DMSA scan was done elsewhere, which reported as scars in both the kidneys with differential renal function of right kidney 48 and left kidney 52%.
Okay.
So, based on this information, sir, again, I would like to say that at the 3 months, the creatinine came down, but it's still on the higher side because of the renal dysfunction. And also there is a hyperkalemia with potassium of 5.6.
Yes.
DMS showing bilateral scars, but functions, relative differential functions are okay.
So, any more information available on this child?
Sorry, sir?
Any more information available, or this is all?
Slide.
Sir, I would like to compare I would like to do ultrasound also, sir, and the MCU details and ultrasound abdomen, pre and post. I don't know the first of all, I will ask the clinical history. What is the symptoms of it? Either child is voiding because it's now 3 months. Mother could have given more information whether the child is dribbling or what is the status of basically vesicostomy. It's either dribbling or it's not functioning. The child is voiding per urethral. That all details I know. Also, I would like to know the feeding status. I mean, any the growth retardation, feeding history, and UTI episodes within these 3 months.
There is no UTI episode in this last 3 months, and voiding in feeding history was given, sir. Can you go for the next slide?
Yeah.
Sir, the child has again history create of 1 at 1 year was 1, and at 2 years was 1.7. He is under follow-up at the native place with the pediatrician and the pediatric surgeon there. So this is what information we have.
So you've done it. There's a DMSA done. Have you done any, or did the DMSA has given you information about the drainage of the kidneys? Dr. Nayan?
Sir, your audio is not clear. Sorry to, I mean.
Okay. I'm saying that how the kidneys are draining.
Sir, drainage pattern, sir?
Yes.
Sir, based on the DMS, I cannot comment on the drainage, sir.
So that's why you can do a DTPA or an EC.
Yeah, EC or DTPA we can do for drainage.
Yeah. At this point of time, we must know that the raised creatinine is reversible or not.
Yes, sir.
Because if there is a supravesical obstruction still remaining, then you can still intervene.
Yes, sir.
So that information is.
Yes, sir.
So what would be advice? 2 years, the creatinine is 1.7 milligram %, and we don't know the status of his voiding and drainage of the kidneys.
Yes, sir. So first of all, I would like to evaluate the child. So I will do the urine analysis and culture to rule out the UTI. I would like to do the ultrasound, complete ultrasound abdomen pre and post to check the upper tract, I mean kidney status, the hydrouretral nephrosis, also the bladder status, whether vesicostomy is functioning or not, and the status of the posterior urethra, whether it's dilated or not.
Yes.
And after this initial evaluation, based on these reports, if I have a doubt of, I mean, a lower tract issue, then I would like to repeat the MCU because I don't have any previous detail of MCU as well.
Okay. Is it available? Is MCU available?
Yes, sir. MCU available, sir.
Okay.
Go to the MCU. The voiding history, sir. The mother gave the history that the child used to have dribbling constantly from the vesicostomy, and the child fluid intake was 2 liters, and child keeps demanding for the fluid and no UTI, sir. And very occasional voids per urethra also. This is a voiding history we have.
Okay.
Next slide.
So this is on examination, sir. Weight was 8.1 kg. So with height of 75 centimeter. So it's obviously it's a low weight for 3 years, so a 3-year child. The blood pressures were 110 by 90 mmHg. That is also on the higher side. And patient on presentation was irritable. On examination, vesicostomy was healthy and the bladder was palpable. Also, phimosis was noted on examination.
Dr. Mahesh, can you mute your mic if you are not speaking? There's a background noise there. Dr. Mahesh.
Yeah, okay. Sure.
So HB was 10.2, sir. So the child was anemic with creat of 1.95 and the potassium was on the higher side. Urine analysis we have done showed the protein trace. That is one good thing because there is no significant proteinuria in spite of this renal dysfunction. but WBC of 8 to 10 noted. Urine culture reported no growth. So after this evaluation, I would like to do, as I told you, ultrasound and the X-ray KUB, sir.
Yeah, we have the ultrasound and X-ray. Proceed. This is the KUB of the child.
Yeah.
So here, sir, I would like to say the positive finding in the X-ray KUB is there is no vesical calculus, because usually if vesicostomy child may present sometime with the vesical calculus and history of UTIs, but there is no vesical calculus. But obviously there is a rectal loading noted. That may be the one of the management part later after detailed evaluation. So I would like to keep in mind this positive finding from the X-ray KUB.
What is the significance of rectal loading?
Usually, sir, I mean, the child, if having the constipation history of rectal loading, the lower ureteric symptoms, in spite of our anticholinergics, specifically in the PUV childs, they may present with the recurrent UTIs and the incontinence and other lower ureteric symptoms. So the bowel clearance is must, specifically in the pediatric population.
Yes. And that too, and when the creatinine is little on the higher side, this will be further aggravated.
Yes.
Okay.
Next slide.
Yeah.
The kidneys.
So, sir, the ultrasound of right kidney image, image is not there, but still I can see the moderate hydronephrosis, hydroureter nephrosis. Rather, upper ureter is also looks dilated with thinned out parenchyma at the mid pole. The second image showing the left kidney, the similar findings I can see, the moderate to severe hydroureter nephrosis with thinned out parenchyma. No obvious stone or hyperechoic shadows, so stone noted. And this is the bladder image, transverse image, showing the partially filled bladder, but I can see the dilated lower ureters. There is no obvious vesical calculus or I can say dilated posterior urethra in this particular image.
So with these findings, what would be your next plan? We are seeing that the dilated ureters are there and the creatinine on the higher side.
So I have, sir, two things in mind as of now. One is the creat is in the higher side, and the second ultrasound is showing there is a moderate to gross hydroureter nephrosis, but I don't have to compare for this finding. So I would like to check the lower tract by doing the MCU. So I have a better idea of lower tract. As the upper tract is showing there is a hydroureter nephrosis, I would like to do further MCU after urine culture report.
Okay.
And the other thing is, I would like to check the vesicostome is functioning or not. So if the post-void residue, I have to look in the ultrasound.
Yeah, that information is there. Can you go for the next slide? Postword residue is nil, sir, and bilateral hydro, as mentioned, the diameters with parenchymal thickness in both the kidneys.
Okay, sir, I would like to proceed with the MCU. Here they mention the postword residue of nil.
Yes.
But mother says child is voiding occasionally per urethra, and also there is a continuous dribbling from the vesicostomy. The bladder was palpable on examination, but ultrasound showing a nil postword residue. So I'm not sure, whether the vesicostomy is functioning or not.
No, it will be good to examine the child and see the vesicostomy site. See,
Yes, sir.
every time the vesicostomy get closed.
Yes, sir. Yeah.
You have the MCU?
Yes, sir.
Yes.
Okay.
So this is the MCU film, sir. The cystogram. showing the right side grade 5 viewer. The bladder looks, I don't know the detail of the MC, but looks a good capacity with smooth outline, and bladder neck looks competent. There is no viewer on the left and no contrast in the urethra. Mild trabeculation I can see on the posterior, superior posterior wall of the bladder.
So is there a film to show the posterior urethra?
Sorry, sir?
Next
This
slide.
is a histogram. Yeah.
So this is the voiding film, sir, showing the right side grade 5 viewer with the voiding film showing opened bladder neck with dilatation of the posterior urethra. There is a clear cutoff at the posterior urethra. Beyond that, there is a mild density of the contrast trim. So based on these findings, I would say there may be the residual wall or the possible of the stricture because of the prior fulguration. So to confirm this too, I would like to do the cystoscopy for the child.
Yes. Yeah, that's a good point.
Sir, you have to unmute, sir. Arup, sir, you have to unmute. Yes, sir.
Yeah, I was saying it that it's always good to differentiate whether it's a residual valve or a stricture has developed at the point of fulguration.
Yes.
So the lower tract obstruction status is assessed.
Yes, sir.
Yeah.
Next slide.
Yeah.
Sir, through the vesicostomy, the Foley was placed, and we found out the child after 1 week, and the creat has come down from 1.9 to 1.6 post Foley through the vesicostomy side, and the ultrasound showed the same hydronephrosis as before, no change in the hydronephrosis.
So, meaning thereby, this child has got an obstruction below the bladder, either because of the residual valve or the stricture, and the vesicostomy is not working properly.
Yes.
Okay. So, how do you want to manage?
Sir, as creat is came down marginal, but still at the higher side, I will plan the cystoscopy to confirm the lower tract is clear or not. Obviously, I'm still showing there is a narrowing. So I will do the cystoscopy. If cystoscopy is showing the stricture, then I have to manage the stricture. But this is the 3-year child, so obviously I will counsel the parents regarding the CIC. As per our protocol, we will if any stricture we found in our institute, we'll address the CIC once in a day. So we'll counsel the parents accordingly. If cystoscopy, I feel, if I found there is a residual wall, then obviously I will fulgurate the wall. I'll put the catheter and I will see if creat is improved, if any improvement in the hydrourethral nephrosis, and then I will plan further. If creat is improving, no UTI episodes, so then after fulguration, I will, final plan will be the vesicostomy closure.
Would you like to do anything on that reflux? Right sided reflux?
Obviously, as of now, no, sir, because I have clear-cut outflow issue here. I will not operate on the viewer. I will first clear the lower tract and then I will follow it up.
Yes, and moreover, there is no issue of significant UTIs.
Yes. If there is no sepsis or UTI episode, then I will wait.
Dr. Nayan, I'd like to take you to a different side of discussion. Is what is the outcome of this child? Suppose you have tackled the lower tract and
Yes,
is like this 1.6. I mean, this is another creation most likely.
Sir, this it's now it's in the category of the chronic kidney disease because creat is 1.6. So obviously there is a renal dysfunction. Maybe whether because of the inborn renal dysplasia or a lower tract issue. So the main important thing here is to counsel the parents regarding whatever the child is suffering from the renal dysfunction. So basically, our aim here is to prevent the UTI episodes and maintain the renal function. So for that, we have to take care of the upper and lower tract. For upper tract, we need the nephro consult on the regular base. So, and accordingly, we have to put him on some medication, antihypertensives, and the vitamin D and the anemia correction. All this for lower tract, obviously that is our part. So we will ask child to be regular follow up. We explain the time wording urotherapy, bowel clearance, and the anticholinergics, and on follow up based on the urodynamics. We have to follow the child, and we have to continue the anticholinergics, and if required, on the follow-up MCU, we may need. I mean, in our practice, I mean, our the institute, we follow the bladder neck incision if we feel that there is a high bladder neck. So, if child present with the recurrent UTIs, in spite of after the fulguration, MCU showing the clearance of the wall, and the cystoscopy showing the high bladder neck, in spite of the alpha blockers, if UTI episodes increase hydro, then we'll advise the parents to go for bladder neck incision. But though there is no the improvement on the renal function for after all this intervention.
So my the parents might be asking you,
Yes.
well, what is the outcome? What is the expected outcome of this child when he become adult?
Sir, I would say at the age of the 20-30 years, obviously he will end up in the CKD state, and he may need the dialysis and further.
So he will reach an end stage kidney disease.
Yes, sir. End-stage kidney disease, and he may need the transplantation.
Yeah. So therefore, the importance of the antenatal ultrasound to detect these severe cases of posterior.
Yes, sir.
So let me ask, if you find on antenatal sonography, say second trimester,
Yes,
you
sir.
find a severe degree of hydronephrosis, what are the diagnoses that come to your mind?
Sir, in the two parts, I will discuss the management with the parents. The one is I will I will explain what are the fetal interventions that we can do for the.
Don't go to intervention. I said you have found a severe degree of hydronephrosis.
Yes, sir.
In a child in a pregnancy which is second trimester, say 24 weeks.
Okay, sir.
So what are the possibilities?
For differential diagnosis.
Yes.
Yeah. So if for only hydronephrosis, sir, I need the ultrasound details. Sir, if any hydronephrosis, then.
So you classify it is hydronephrosis or it is hydrouretronephrosis.
Yes, sir.
Okay.
So if it's a hydronephrosis, first I mean differential diagnosis I would like to put is transient hydronephrosis. If it's a mild degree, it may resolve. Most of the times it will resolve, sir. The second would be the PUJ obstruction. The third would be the VUR on that side, particular side. Fourth would be the renal dysplasia. I mean the renal medullary dysplasia.
Cystic disease.
Cystic disease, sir. And last will be the lower tracheal, lower. If any, there is a hydrouretronephrosis, I would say any ureterocele or bladder issues or lower urinary tract obstructions like PUV or anterior urethral valve or urethral atresia or any.
So of all those you utter, the commonest being, if it is only hydronephrosis, it is severe degree of PUJ obstruction.
Yes.
And if it is bilateral hydrouretronephrosis with distended bladder, it is posterior urethral valve. So these are the common things, and we should keep these in mind. Difference will come always. Okay.
Yes.